Welcome to this explainer. Today, we're looking at something that is frankly one of the most intense, time-critical cardiovascular emergencies in all of medicine, the aortic dissection. When a patient rolls in with this, the normal rules of slow, deliberate medicine, they totally go out the window. We're fighting a ticking clock here, where every single minute fundamentally alters their chances of survival. So, put on your clinical hats, because we're going to break down exactly how this massive mechanical failure happens, how we spot it before it's too late, and most importantly, how we fix it. So, to really grasp the gravity of this situation, let's look at the definition. At its absolute core, an aortic dissection is a catastrophic structural failure. We're talking about a physical tear in the innermost layer of the aorta. This tear allows high-pressure blood to just surge straight into the vessel wall, literally splitting the layers apart. And without rapid intervention, the mortality rate for an acute dissection in the ascending aorta goes up by roughly 1 to 2% for every single hour that passes. That's the ticking clock I was talking about. You're basically watching a major structural blowout happen in real time right inside the chest cavity. Okay, let's dive into the agenda for today. We're going to start with the pathophysiology of intimal tears, then move into complications and cardiac tamponade, review our initial radiographic findings, get into definitive diagnosis via CT, and finally, wrap up with surgical and endovascular repair. All right, Section 1, the pathophysiology of intimal tears. This right here is exactly where that clock starts ticking. Just look at the sheer mechanical force at play here. The innermost lining of the vessel, the tunica intima, has completely ruptured. You can actually see that distinct white intimal flap just peeling away. The exact moment that tear happens, the high-velocity, highly pressurized blood shooting straight out of the left ventricle, it doesn't just flow past it anymore. It catches the lip of that tear. It acts almost like a wedge, driving a highly pressurized column of blood directly into the muscular middle layer of the aorta. It's essentially carving out a totally new, unauthorized anatomical channel right before our eyes. Crazy, right? Let's codify exactly what's happening. The intimal tear is the match that lights the fire. Once that high-pressure blood forces its way into the tunica media, it creates what we call the false lumen, this new pathological channel. The original, healthy path for the blood, that's the true lumen. Now, because systemic blood pressure is so incredibly high, this false lumen doesn't just sit there. It actively propagates. It literally unzips the aorta. And this unzipping can tear antegrade, meaning forward, heading down toward the abdomen and legs, or retrograde, tearing backward right towards the heart itself. Which actually leads us directly into Section 2, complications and cardiac tamponade. We're zooming out from that isolated vessel to see the devastating impact on the whole cardiac system. So in the absolute worst-case scenario of a retrograde dissection, look really closely at the base of the aorta. The dissection has tracked backward and completely compromised the aortic root. But the destruction doesn't just stop at the vessel wall. No, it's ruptured outward, leaking a massive volume of blood directly into the pericardial sac. That's the tough, fibrous membrane that's really just supposed to protect the heart. You can clearly see all that bright red blood pooling heavily around the ventricles. And the crucial thing we have to understand here is the consequence of all that pooling blood, which is pericardial tamponade. See, the pericardial sac, it's really not very stretchy. So when it rapidly fills up with high-pressure arterial blood from a torn aorta, the pressure inside that sac quickly shoots past the pressure inside the heart chambers. The heart is literally getting crushed from the outside in. The right ventricle simply cannot expand to fill with blood during diastole, and well, if the heart can't fill, it can't pump. Cardiac output just plummets to zero, leading to incredibly rapid, fatal shock. This specific complication right here is a massive driver of why proximal aortic dissections are so lethal. All right, let's transition to Section 3, initial radiographic findings. Imagine we're standing right in the emergency department triage bay. The patient just arrived, they're in absolute agony, and we need data, like right now. On a standard portable chest x-ray, I want you to focus on the center of the chest, the mediastinum. Notice how it's just too wide. That central white shadow is bulging outward. This is what we call the classic widened mediastinum. It happens because the aorta itself is physically expanding from that false lumen filling up with blood, or because blood is actually leaking into the surrounding mediastinal space. But here's the catch, and it's a big one. While it's a classic sign, it can be incredibly subtle. Or honestly, it might just be obscured entirely by poor patient positioning or bad inspiration. And that brings us to a really vital clinical contrast: chest x-ray versus CT angiogram. Look, the chest x-ray is fantastic for rapid triage. It takes mere seconds. But
It's vague, and it has dangerously low specificity. A widened mediastinum could be a lethal dissection, sure, but it could also just be a technical artifact. And to save this patient's life, we absolutely cannot operate on a maybe. We need a definitive answer. We require a CT angiogram. The CT is definitive, it boasts incredibly high sensitivity, and most importantly, it lets us actually see the internal structural failure, the intimal flap itself.
Let's move straight into section 4 and take a look at that gold standard, definitive diagnosis via CT. Okay, put on your radiologist glasses for a second and look at this axial CT cross-section. Look dead center at that massive, bright white circular structure. That's the aorta, all brightly lit up by intravenous contrast eye. But look right in the middle of it. Do you see that distinct, dark, curving line just slicing right through the bright contrast? Yeah, that is the intimal flap. We are literally looking at the torn lining of the blood vessel just fluttering there in the lumen, cleanly dividing the whole vessel into a true lumen and a false lumen. The exact second you spot that dark line on a CT, the diagnosis is 100% confirmed, the debate is entirely over, and the surgical teams are being mobilized immediately. Which takes us right to our final section, surgical and endovascular repair. Because a mechanical failure of this magnitude, it demands an immediate mechanical solution. When we compare our two main surgical options, over on the left, you're seeing the open surgical approach. The chest is cracked open, the diseased, torn section of the ascending aorta is physically cut right out, and a synthetic white fabric tube graft is meticulously sewn in its place. It is highly invasive, but it is absolutely unequivocally necessary for proximal tears. On the right, though, you see a completely different paradigm. Thoracic endovascular aortic repair, or TEVAR. This is minimally invasive. They take a wire mesh stent graft, deliver it via a catheter all the way up through the groin, and deploy it from the inside. It basically plasters that torn flap right back against the wall, perfectly sealing off the false lumen. So how in the world do surgeons choose between these two drastically different approaches? Well, it all comes down to the Stanford classification. If the dissection involves the ascending aorta, the part closest to the heart, carrying that massive risk of retrograde tamponade or shearing off the coronary arteries, that is a Stanford type A. And a type A mandates immediate open surgical repair. Literally, there is no time to waste. However, if the dissection is confined only to the descending aorta, completely past the vessels branching up to the brain, that's a Stanford type B. In that case, the patient is very often a candidate for that less invasive endovascular stent, the TEVAR, combined with some really aggressive medical management of their blood pressure. Wow, we have covered a tremendous amount of ground in this explainer today, from the microscopic tear all the way to the macroscopic surgical fix. But before we go, I want to leave you with a real-world clinical puzzle. Both an aortic dissection and an acute myocardial infarction, a severe heart attack, can present with sudden, agonizing chest pain. So picture a chaotic emergency department. A patient is crashing right in front of you. How might you rapidly differentiate the tearing chest pain of an aortic dissection from the crushing pain of an acute MI? Especially knowing that giving standard blood thinners for a heart attack could be an instantly fatal mistake if it's actually a dissection. Think about the radiation of the pain. Think about blood pressure differentials between the arms. And remember everything we just talked about regarding the sheer mechanical force of an unzipping aorta. Let that guide your clinical intuition until our next explainer.